Well, thank you. I've been asked to address the question of reflux in esophageal inspection, the role of PPIs. I think this is quite an important clinical question that really sets the scene for my co-presenters in terms of how they will be able to detect important lesions. So I'm just going to take you through a couple of sort of questions that came to my mind about this subject. And the first one is addressing the issue of why would you stop a PPI prior to endoscopy to find reflux? Firstly, the patients will not thank you because reflux is an unpleasant symptom. But I'm going to put it to you that actually stopping reflux is contributing to a lot of unnecessary endoscopy and actually is inhibiting our ability to carry out high-quality endoscopy. Now, I just want to share with you some of the times, and this is clearly something we talked about yesterday, the difference in different healthcare systems. In the UK, we have significant waiting times for diagnostic endoscopy. If you look at the bottom, this is data from 2023. There were over 66,000 patients waiting for a diagnostic endoscopy in the UK, some of whom, nearly 20%, 13,000, will have waited over 13 weeks. Coming back to my presentation this morning, we're simply endoscoping the wrong people for the wrong reason. If we were to do less gastroscopy, if we were to treat people with PPI, then that would free up resource for colonoscopy, bowel cancer screening, and actually finding other serious pathology. But let's come on to this next question. Why are we doing endoscopy in patients with suspected esophagitis at all? I'm sure people will be saying, oh my goodness, if we don't do that, we're not going to find upper GI cancer. Raf will be saying, but what about, finding Barrett's? If we don't scope people with Barrett's, how are we going to, with reflux, how are we going to find Barrett's? I'm going to come back to one of my slides from this morning. Look at the bottom line here. If we endoscope, this is from the UK National Endoscopy Database, if we endoscope patients with reflux, the predictive value in women of finding cancer, irrespective of age, you can see the first column here, is less than 1%. That doesn't reach the trigger factor that would suggest to us that the patient has got a high chance of cancer. We are terrifying patients into endoscopy. And in men, it's the same. Now, the other thing about this, this thing is that, of course, finding cancer goes up with age, but we're looking for the wrong patients. When we look in the reflux population, we're looking for cancer in the wrong population. So how will we find Barrett's esophagus? I mean, this is an interest of mine and members of the panel. We have to be able to find early Barrett's cancers. Well, I'm going to talk to you a little bit about symptoms in Barrett's, and of course, then we have alternatives. We have cytosponge and other technologies. So how do symptoms predict the presence or absence of Barrett's esophagus? Again, data from the National Endoscopy Database. Look on the top line here. You can see, of course, with age, there is an increasing prevalence, both in men and women with age, of finding Barrett's in a population with reflux. So to put this clearly, in women under the age of 60, the chance of finding Barrett's esophagus is actually really low, and in men under the age of 50. So if we're going to use endoscopy to find Barrett's, then we should be targeting that resource. Give the patients PPI and then look for targeted endoscopy rather than a bland approach. So really important. Now, the thing I want to point out to you is when I've suggested this before to others, people have said, well, you have to look in reflux for Barrett's esophagus. Look at the other things, anemia, dysphagia, nausea and vomiting, and look at the prevalence of Barrett's findings. The population have Barrett's esophagus due to long-term reflux. Reflux as a symptom does not predict a much enhanced risk of finding Barrett's. So if we say simply that based on symptoms, we should screen for Barrett's, we're missing a lot of patients. We're missing a lot.
One final thing I think that often helps me, and I don't know what you all think, is narrowband with acetic acid. Because you then get a really beautiful outline of the vascular, and you can see what's happening. The glands are crowding together. In the middle, for me, it's irregular and it's lost. So for me, this is a cancer, which we will later, as Eduardo and I were talking about the pros and cons of different resection techniques, but that is not the focus, sadly, of us here.
So the next patient is a 75-year-old man who is an ex-smoker and daily drinks alcohol. In 2003, he had a Helicobacter pylori-induced ulcer treated with eradication antibiotic therapy. And last year, he had a diagnosis of of 2 primary upper GI tumors, one in the stomach and adenocarcinoma in the antrum, which was treated with ESD because the patient was not fit for surgery. And in the proximal esophagus, there was an invasive, moderately differentiated squamous carcinoma, which was treated with definitive radiochemotherapy. So today we will do an esophageal evaluation after radiochemotherapy.
We have maybe a question from the audience, a person who's asking, say you have somebody with an inlet patch who's complaints of reflux of esophagitis, like coughing, a bit of laryngitis. They're treated on maximum PPI, but they're still complaining. And it goes with the next question, actually. Would we treat this with some ablative therapy? Is there anything you found on that?
I think the first step would be to look for H. pylori, and that's quite common. Again, whether eradicating the H. pylori from the gastric side or the esophageal side makes a difference, we're unclear, but either way, if the patient gets something gained from that, then it's worthwhile to looking for H. pylori. If it's really refractory to, and you've excluded H. pylori and refractory to PPI, then I think it's emerging using APC and RFA to these lesions, and it does appear quite safe. So if your patient is burdened with quite a bit of symptoms and you haven't found any other cause, firstly, of course, exclude other causes, then it may be a worthwhile therapy to try. But these are just really limited to case reports with no large studies yet.
And maybe take a biopsy as well?
Sure, yeah. So biopsy to look for H. pylori and exclude more.
I think RFA might get quite expensive. Is there anyone here who does APC of those inlet patches, Raf?
Yeah, I think APC works perfectly fine. And now we just inject first a little bit with some saline just to
make it safe.
If it's a very large patch on both sides, we usually do it in 2 sessions to avoid the risk of strictures and not to have a circumferential ablation during the same session.
Have you had any adverse events from APC?
No, not so far. I mean, it's also not something that we do regularly. It's because, as you say, they need to be symptomatic. You never treat these lesions unless you have throat symptoms like a lot of slime production or throat ache, something like that.